Welcome to the EMEUNET podcast, a place for educational rheumatology content to improve research and patient care. This is the first of what we hope will be a new podcast series on COVID-19 related topics for rheumatologists and the EMEUNET community. Here we want to highlight new initiatives and publications about COVID-19 in the field of rheumatology. So my name is Kagstrup, and I'm recording from Aarhus in Denmark, and I'm your host today. In this episode of the EMEUNET podcast series on COVID-19, we will focus on the COVID-19 Global Rheumatology Alliance, and more specifically on the healthcare provider-entered registries. So together with me, I have Felice Rivellese from London in the UK, who's also the chair-elect of EMEUNET, and he will help me to introduce our speakers.
So thank you too. It is a pleasure for me to introduce our guests. So we have with us today Dr. Philip Robinson from the University of Queensland in Brisbane, Australia, who is the chair of the COVID-19 Rheumatology Alliance. So good morning, Philip. I think it's about 7 a.m. in Australia, so I can say good morning. We have Jinoos Yazdany from the University of California, San Francisco in the United States, who is the vice chair of the COVID-19 Rheumatology Alliance. And I can say good afternoon, since it's about 2 p.m. in San Francisco. And then we have Dr. Pedro Machado from the University College London in the United Kingdom, who is part of the EULAR COVID-19 steering group. So I'm not going to say good night, but just hello, everyone. In London, it's 10 p.m. So it was really a big effort to have people from different parts of the world and different time zones today to discuss this very important initiative. So we agreed before starting that within EMEUNET, we are very relaxed. So we're going to call you by first names, if that's okay for you. So I will ask my co-host to start with the first question.
Okay, thank you, Felice. So I would like to start with Philip. Will you please give a brief introduction to the why and the how the COVID-19 Global Rheumatology Alliance registries were formed?
Yeah, so it's an interesting story because it was a discussion on Twitter that was brought up by a rheumatologist in Cleveland, Len Calabrese, and essentially he pointed out that the inflammatory bowel disease group had set up a registry, and that essentially precipitated a discussion amongst rheumatologists about, look, that this would probably be a really good thing for rheumatology since our patients are commonly on immunosuppressants. So essentially that got the conversation started, and essentially it went from there and went from just a handful of people up to hundreds of people over a very short time span. So within a matter of days, we had over 100 people all contributing and wanting to help. And the why is that so we didn't really have a lot of information about what was happening. But it was very clear that this was going to be a pretty massive event in terms of patients, in terms of numbers, and in terms of potentially how our patients were going to be affected. So our patients already have an underlying dysfunction of their immune system mostly, and then we introduced further dysfunctions by treating them with medication. And then there was also these discussions sort of percolating about, well, maybe some of our drugs might be helpful in the very unwell patients, in the cytokine storm sort of type patients. So there are lots of reasons why our patients and the medications that our patients use were going to be really relevant, and so that sort of drove the why we thought it was important, and then. Clearly, everyone else that was around and involved felt it was too, because we've been inundated with people wanting to help and contribute.
And so to sort of further introduce the registries, can you please clarify what questions these registries can help answer to improve patient care in rheumatology?
So I think we were very clear at the start about the limitations of the data and about what we would and would not be able to answer. But essentially, because of how we're collecting the data and what we're doing, essentially it's going to be a large, essentially complex case series, and the sort of questions that we're going to be able to answer is broad, but also potentially hypothesis generating questions. So one of the things that people were very worried about prior to information about cases was, are all of our patients going to be very severely affected and going to become unwell or have really poor outcomes? And, one of the questions that we were able to answer very early on, just from the initial data that we've had, is that really it's very clear that that's not the case, and that many of our patients do absolutely fine when they become infected on our medications. Now, there are other patients that don't, but essentially there was a lot of anxiety out there amongst patients and amongst rheumatologists about, how this was going to affect broad brush patients. And essentially early on, we're able to say that this was not a universal thing that people would have poor outcomes. And then later on, as we get more detailed information, we're able to look at things like the relationship between outcomes and medications. And we've already been able to do some of that with hydroxychloroquine and provide information about that. But I suppose the thing to emphasize is that there are limitations in the data, and because it is a series of patients that are introduced to the registry, there are biases about how they are introduced. So it's very important that when we think about the data and we think about potential conclusions that we can draw from it, that we're very careful that we maintain in the front of our minds about the potential biases that come with that information.
So yeah, thank you, Philip, also for your word of caution about biases and the limitation of data, which I think are quite important, especially this time. So if I can ask Pedro, because we just heard from Philip that the COVID-19 Rheumatology Alliance was developed very quickly and everything was organized in a few days. So could you please tell us how the European side, the European registry was started and how it was developed?
Yeah, sure. So, well, first of all, thank you very much for the invitation. I'm really glad to be here. Now, regarding your question, so the Global Rheumatology Alliance, they were seeking endorsement from various institutions, and EULAR was also approached. Now, to EULAR, it was clear that it was really important that there was one single registry, because that would increase the power and the ability to answer the questions that Philip just highlighted. And it was our strong belief that a collaborative approach would be critical for the success of this type of initiative. And that's when we embarked in this partnership with the Global Rheumatology Alliance. Now, due to international data legislation, in particular the European General Data Protection Regulation, known as GDPR, what we decided to do is to establish parallel data entry points, one limited to European countries, and the other one being the global entry point. Now, both data entry points are linked to secure platforms, and these are RedCap platforms. And the European platform is hosted by the University of Manchester in the UK, while the global platform is hosted by the University of California, San Francisco in the US. And I guess the final thing I'd like to highlight is that the European registry is also covers pediatric cases, not only adult cases, and it has been endorsed by the Pediatric Rheumatology European Society.
Okay, so a little bit more about data protection. This is for you, Jinoos. As I understood, you have been heavily involved with this. So will you please briefly describe the institutional review board approval for the Rheum COVID registry participation, and specifically try to answer the following two sort of related questions. Is individual patient content required for providers to enter data into the registry? And secondly, would I need to get approval from my local IRB?
Those are great questions. So our very first step in making sure that we had ethical approval for the project was to seek an IRB from the University of California at San Francisco. And we were very lucky. They approved our protocol within a period of just 3 days. under a category of quality improvement or surveillance research. We decided that we would not collect certain patient identifiers in this effort. So we are not collecting patient name or address or date of birth. And instead, we were going to just collect information about the rheumatologist, the name and email of the rheumatologist. And because of the way that we were collecting data and our data procedures, we were able to get it approved in this way, and it was basically deemed as being not human subjects research, and therefore individual patient consent was not required. Now, in the United States, the UCSF IRB covers all of our federal entities. So, it would cover all of the institutions in the United States, but in order to be, conservative and careful, many of our collaborating institutions across the country went ahead and got, their IRBs to also approve the protocol, just to make sure everybody was in agreement. And so far, the protocol has been deemed either not human subjects research or exempt by all of the and have looked at it. Our international collaborators in many countries around the world have gone through their IRB procedures as well, and each country has a slightly different sort of IRB protocol. In some countries like Canada, individual institutions need to seek an IRB approval. For other countries, there is a possibility of getting a countrywide approval. And so we're just working with people and their local IRBs to sort through the procedures. But it really has been an enormous international collaborative effort with hundreds of people putting in a lot of time to make sure that all of the ethics are in place as we embark on this data collection effort.
So thank you, James. I think this clarifies quite a lot of doubts that people might have had around this ethical approval. So, and I would like to ask Pedro again, going back to Europe. You already clarified some of the differences, and one of the reasons for having different registries was indeed linked to ethical approvals. But if you can speculate a bit more about this, or go a little bit more into details, particularly if you encountered any difficulty in specific European countries.
Yeah, so the situation is actually very similar to the US. And so because the database is hosted by the University of Manchester in the UK, in first instance, we consulted with the Health Research Authority. And according to the UK Health Research Authority decision tool, the EULAR COVID-19 database is not classed as a research study. And therefore, UK NHS ethical approval is not required. It's very similar to the situation in the US in the sense that it can be classed as a service evaluation project, and therefore there's no requirement for patient consent. And although this does not cover all nations in Europe, we do believe that this will be the position likely taken by all, or at least the majority of authorities across Europe. Now, we do ask contributors to please check with the local authority, especially if they are unsure, and a copy of the UK regulatory corresponsible is available on request. So far, in the majority of countries, what has happened is that this was not considered research per se, so ethical approval not required, patient consent not required, and this is considered to be a service evaluation project. There are a few exceptions, so that's why we do ask people to consult locally, and if required, we have documentation that we can provide to help with local approval.
So considering how time-consuming these processes sometimes can be, this is very impressive. So now we're ready to enter something into the registry. And Jinoos, two related questions for you. So which cases should be included, and who should enter a case into the registry? And the second related question, what kind of information is required, and how long will this take?
So those are great questions. So we we really designed this for physicians, so rheumatologists who know their patients well, to enter cases about, really their own patients. In some cases, rheumatologists have partnered with, say, a fellow at their institution, or perhaps a research coordinator to enter data, but in all cases, they should be validating that data, because we really want, sort of the expert adjudication of the rheumatologist to be reflected in the data. We are collecting a variety of information about the case. So it includes things like the medications that they were taking before they became infected with COVID-19, the way that they were diagnosed with COVID-19, the sort of the exact assay that was used to make the diagnosis, and then we're collecting information about whether their medications were stopped or continued during the course of the infection, and then of course information about outcomes. We also include some information about laboratories and even about co-infections with things like influenza and other respiratory viruses. The data collection form was tested and made to be as simple as possible. For most people, it takes somewhere between 5 and about 15 minutes to fill out the survey, and we think that's really important because we know that just many of our colleagues around the world are under a lot of stress. Some of them have been pulled in to take care of patients on the inpatient services, and so we wanted to make the data collection as quick and easy as possible.
Okay, thank you. And Pedro, a somewhat related question. So now we have this case. So when should the case be reported, and what happens if the entering healthcare provider doesn't have all the info?
Ideally, cases should only be reported after the outcome is known. So that would be the ideal point in time. So what we do, we encourage providers to report the case after a minimum of 1 week, and at least sufficient time has passed in order to observe the disease course and the resolution of the acute illness or death, if that's the case. Now, if the healthcare provider does not have all the information, he or she should ideally wait until that information is available. And we, of course, understand that in some cases it may not be possible to obtain all the information, but people should just try to obtain as much as possible, and that would be and once that information has been obtained, that would be the time to report the case.
Okay, thank you. So I think we clarify now how the registries work, but I think it's time for the question that everyone has been waiting for. So how about some data, some preliminary data? I think the Rheumatology Global Alliance has been very I appreciated the fact that you've tried to produce this data and publish it as quickly as possible. I remember already 2 weeks ago, after a couple of days, there were some preliminary data shared on social media, which was really amazing. And then last week, we saw a manuscript on Lancet Rheumatology with data from, I think, the first 110 patients. You were all obviously involved in this publication, but I'm going to ask Jinoos as the last author. Can you please summarize some of these preliminary findings?
Sure. So first of all, just our enormous gratitude to all the rheumatologists who took time to participate. It's really sort of an amazing demonstration of the strength of our scientific community. And, this initial paper was really a proof of principle that with global cooperation, we could rapidly, collect this data during the pandemic. And I think it's truly amazing that just within these over 100 cases to report to our community. So let me just tell you, about these first 110 cases that were entered into the registry. Not surprisingly, most common diagnosis was rheumatoid arthritis. About 2/3 of the patients were taking conventional DMARDs. About 45% were on a biologic. about 1/4 were taking hydroxychloroquine, and many of those patients on hydroxychloroquine had lupus. And then in terms of outcomes, about 1/3 were admitted to the hospital, and 5% died. Now this, this data is early. It's only 110 cases, but even with, the small amount of data, we were able to make some conclusions. I think first and most importantly, it appears that our patients, including those that are on immunosuppression, are able to recover from COVID-19. We're not able to produce precise population-based estimates, but we are able to say that it looks like people are mostly doing okay. And I think that should provide some reassurance to rheumatologists and their patients. The second thing is that, because there were a substantial number of people on hydroxychloroquine in these first 110 cases, we were able to say that people on hydroxychloroquine can get COVID-19, and that people with lupus, for example, can get COVID-19. And this came at a critical time and allowed us to counteract, I think, some misinformation that was circulating to say, regarding hydroxychloroquine at the time. And so I think it's a nice illustration of how even this very early data sort of contributed to our understanding of the pandemic and people with rheumatic diseases. We now have over 600 cases, and so we are in the process of analyzing this data and should be able to release that larger case series to the community soon. So stay tuned for that.
Okay, thank you very much for sharing this. So we talked mostly about the healthcare provider entered registry, but there's also a patient questionnaire. And Philip, pre-recording, you said that there has been quite a response from patients. So can you briefly tell us what are the most recent numbers here?
Yeah, the patient experience survey has really been quite amazing about the response that we've had. So we are currently up over 10,000 responses to this survey, and I think the latest the latest number suggested around 500 or so have been reporting COVID-19 diagnoses, so around 5% of them. In a very similar way to the cohorts that we see in clinic and also our provider registry, we've seen the majority having rheumatoid arthritis, with a substantial proportion, say 20% with lupus, and then the other diseases that we commonly treat in there. There's been a variety of ways that these people have been diagnosed, just like in the community, some with presumptive, some with lab testing. But again, we've seen the same patterns that we've seen with the provider registry, in that we've seen lupus patients and patients on hydroxychloroquine being diagnosed with COVID. So we've seen consistent messages coming out of our different ways of collecting data. And I suppose another thing to bear in mind is that I think that there is a lot of value in collecting these patient experience survey, because the provider registry, by its very nature, is going to potentially attract patients that are more unwell, because they're more likely to get in front of a doctor who's going to put them in the registry. And so I think there's a lot of power in going directly to patients, because those with mild disease who might be diagnosed in the community, who don't get unwell and end up staying at home, are able to engage and tell us that information. Now, it's potentially not as detailed and technical as what we want, but it provides another portal on potentially another group of patients who may not have disease that is severe as those in the provider registry.
Okay, thank you, Philip. And then for you, Pedro, do we also have an update on the numbers from the European database? And related to this, do you think it will be also interesting in the future to look at differences between countries?
So as of yesterday, we have a total of 249 patients reported in the EULAR database. So I suspect that overall, that combined with what's reported in the global registry, we should be close to 750 patients probably. But 249 reported in the EULAR database, which is fantastic. And again, like Jinoos, I would just like to thank all the rheumatologists and healthcare providers in rheumatology that have been helping with this effort and reporting cases. It's been really amazing. Now, regarding your questions about comparing countries, well, I do think it would be interesting, but I would advise a great degree of caution if we ever do that, because there might be different selection bias related to the way that each country is reporting patients, and that will make comparisons very difficult, I think. And the other thing is that we would require a significant and a sufficiently large number of patients reported per country. So while I think the idea is interesting, I think we should be very cautious if we ever do that for the reasons that I've stated.
So thank you, Pedro, and yeah, thank you also again for the word of caution. I think it's, as I was saying before, very, very important to know what type of data we are dealing with. So this has been a very interesting discussion, and on behalf of EMEUNET, I would like to thank Felipe, Jinoos, and Pedro for taking the time to participate to our first EMEUNET COVID-19 podcast and video interview. So we would also like to thank everyone in the COVID-19 Global Rheumatology Alliance for creating these registries, and finally the whole rheumatology community for entering the cases in the registry. So I think I can end by wishing a good day to Felipe, good afternoon to Jinoos, and good night to Pedro, me, and you. Thank you very much.
Thank you very much.
Thank you. Thank you.
This is the end of this episode of the EMEUNET podcast. We really hope you enjoyed the show and found the content useful. For more information on the registries, go to the COVID-19 Global Rheumatology Alliance website. It's called rheum-covid.org. Also, please follow EMEUNET on Twitter and Facebook to keep being up to date with educational content and research opportunities. Thanks for tuning in, and stay safe.